Hello, my name is Emily Eidenshank and my partner is Tori Fisher. We did our capstone project on the treatment of hypertension in the African American community. The first part of our presentation will pertain to our review of literature. Hypertension is known as the silent killer. Long-term hypertension remains the most significant contributing factor to chronic diseases like stroke, kidney disease, and cardiovascular disease. Hypertension is defined by the American Heart Association as a systolic blood pressure of greater than or equal to 130 and or a diastolic blood pressure greater than or equal to 80 milligrams of mercury. The population of African Americans retains the highest prevalence of hypertension among all other races in the U.S. Hypertension is most likely to go untreated in minority populations because they tend to have less access to health resources, causing a greater likelihood for misdiagnosis, lack of treatment, and mortality.
Therefore, our problem statement, since hypertension occurs in most minority populations, although they are typically excluded from research as it's mostly seen to be done on white males, so our purpose of our review of literature is to examine research pertaining to the mechanism and treatment of hypertension in the African American population and discuss the most beneficial interventions for this group specifically.
The scientific community has only recently begun to examine the possible causes of increased rates of hypertension in the African American community. One source of these increased rates of hypertension may be discrimination. A study completed by Moody et al. Examined the effects of everyday discrimination on blood pressure in women identifying as white, Black, Chinese, and Japanese. All participants reported their current hypertension status and then had their blood pressure and measure of everyday discrimination measured. All measurements were repeated once a year for the next 10 years, and the study found that women in minority groups reported higher everyday discrimination and had higher blood pressure than the white women in this study. Another study completed by Sims et al. Had the African American participants of the Jackson Heart study complete a discrimination survey. The participants' answers to the survey were compared to their Jackson Heart study blood pressure data from 2000 to 2004. The data analysis showed that participants reporting greater lifetime and burden of discrimination had significantly higher prevalence ratios of hypertension. Additionally, a study completed by Gabriel et al. Examined how differing amounts of social support may mitigate the relationship between race and hypertension. The participants of the study were Caucasians and African Americans from similar socioeconomic backgrounds. The participants had their blood pressure measured and had their level of social support and racial discrimination measured via survey. The study found that African Americans experienced greater discrimination and had a higher prevalence of hypertension than Caucasians of similar status and with similar amounts of social support. Many researchers believe physiological responses to the increased stress caused by discrimination may cause increased blood pressure in minority populations. A possible physiological cause of increased blood pressure is the activation of the sympathetic adrenomedullary system, where aldosterone is released in the body. A study by Kindambi et al. Postulates that the constant release of stress hormones such as aldosterone leads to sodium retention in the body, which increases blood plasma volume and blood pressure in the African American population.
In our aerobic intervention section, we found, as previously stated, that most studies were completed on white male counterparts and that the novelty of exercise is not as true as it appears, so it may not be as effective as those who live in certain environments that are not suitable for exercise, those who are contraindicated for exercise, or lack the motivation or the financial means to go to a gym, as is not as easy as go run outdoors. And we found that African Americans' blood pressure shows minimal to no differences in aerobic intervention. In a study done by Randa Dive et al. In 2015, it was an 8-week program with 64 young adult participants, half Caucasian and half African American, and they could bike, jog, run on a treadmill, or use the elliptical. And this was done 3 times a week with a 5-minute warm-up. And then they exercised 35 to 40 minutes. In the first 2 weeks, they worked at 65 to 75% of their VO2 max, and then this increased to 85% of their VO2 peak, for the last 6 weeks. So they found no significant reductions in their blood pressure. However, there's improvements in pulse pressure, and they found African Americans had a higher intermedial thickness, which decreased with aerobic exercise. And this is important as this allows blood to flow through the vessels, and having a higher intermedial thickness leads to hypertension possibly and other cardiovascular events. Whereas in a study by Ehrheller et al. In 2014, they followed a 6-month protocol with 26 middle-aged African Americans, and they were allotted to do activities like stair stepping, being on the treadmill, cycling, rowing, and cross training. And they also practiced 3 times a week, beginning with 20 minutes in duration and progressing to 40 minutes. And they also progressed their VO2 max workload from 50% to 65%. And they found improvements in vascular and structure, VO2 max, and BMI. However, no beneficial changes in any BP measures, and these included sleep blood pressure, awake blood pressure, ambulatory blood pressure, and 24-hour blood pressure. And then in a study by Corso et al. In 2016, this was a 12-month intervention, which adds to the validity of the study. And this was done in a general population of 88 middle-aged worksite cleaners with high occupational activity. And they were able to do cycling, treadmill running, other aerobics on their job site 2 times a week for 30 minutes, where participants completed aerobic exercise at 60% of their VO2 max. And similarly to other studies, they found improvements in VO2 max. They also found decrease in resting heart rate, decrease in BMI, body fat, and waist circumferences. And again, no significant decreases or differences in blood pressure measurements. And finally, in a study by Bunswat et al. In 2021, this was a singular experimental protocol with 36 young adults with and without obesity. And this was one 60-minute cycling session at 60% of their VO2 peak after a 5-minute warm-up at a cadence of 60 revolutions per minute, greater than or equal to this value. And they found significant decreases in resting brachial and arterial blood pressures at 30 minutes and 60-minute time points post-exercise, although at 90 minutes, their blood pressure returned to pre-exercise values in both populations. And furthermore, sub-analysis showed there were no significant changes in women's blood pressure of obese and healthy compared to the men. Therefore, women may be less susceptible to aerobic exercise changes in the cardiovascular system. So therefore, we found no significant long-term decreases in blood pressure from aerobic exercise. VO2 max will increase, resting heart rate may potentially decrease, and BMI decreases as well as body fat, along with other anthropometric measures.
Mindfulness meditation is a form of meditation that has the individual focus on their breathing and current thoughts, feelings, and bodily sensations in order to reduce stress. This stress reduction aspect may make mindfulness meditation a beneficial option for minority populations who suffer from increased stress due to discrimination. Mindfulness practices are also more accessible to persons with low socioeconomic status or those who are contraindicated for exercise. Mindfulness meditation has been shown to decrease blood pressure in long and short-term interventions and in differing populations. One study completed by Parswani et al. Tested the effectiveness of mindfulness meditation on middle-aged men with coronary heart disease. The participants of the study completed 2 30-minute guided meditation sessions each week for 8 weeks. The meditation sessions were led via recorded audio and consisted of a body scan, sitting meditation, and cognitive restructuring with paced breathing throughout the session. After the intervention, participants in the experimental group experienced a 5 milligram of mercury drop in systolic blood pressure. Additionally, Chen et al. Had 30 nursing students attend a group mindfulness meditation session led by an instructor for 30 minutes every day for an entire week. These instructed classes included background music and the incorporation of Chinese Buddhist concepts. Subjects concentrated on their breathing with their eyes closed and allowed themselves to enter a non-judgmental state. After this mindfulness intervention, the nursing students had significantly decreased their anxiety and systolic blood pressure. The research on mindfulness is still limited, but there are a few studies on the African American population specifically. The first study was completed by Polta et al., who tested the effects of mindfulness-based interventions in the African American older adult population. The experimental group of this study was guided through the Eldershine Mindfulness Program for one 90-minute session each week for 8 weeks. The sessions consisted of meditation and lessons on applying mindfulness to self-care and relationships. Blood pressure of the participants was measured before and after the 8-week intervention. The group receiving the intervention had a reduction in systolic blood pressure of 21 milligrams of mercury and in diastolic blood pressure by 16 milligrams of mercury. The benefits of mindfulness in the African American population were further exhibited by Bell, who investigated the effects of mindfulness meditation, eyes closed meditation, and silence on 57 young African Americans. Participants completed their assigned conditions for 30 minutes 4 times a week for 12 weeks, while connected to a device obtaining heart rate and blood pressure measurement. The study concluded that the mindfulness intervention produced the most significant decreases in systolic and diastolic blood pressure, as well as heart rate measures when compared to the other conditions. Another study completed by Park et al. Shows the possible mechanism by which mindfulness meditation lowers blood pressure. In this study, 15 African American males with hypertension and chronic kidney disease completed a 14-minute mindfulness meditation while their blood pressure, heart rate, respiratory rate, and muscle sympathetic nervous system activity were taken continuously. All physiological measures, including blood pressure, decreased during the meditation session. The most significant finding of this study is that muscle sympathetic nervous system activity significantly decreased during the session. Muscle sympathetic nervous system activity has been shown to raise in correlation with cardiac noradrenaline, illustrating that it is linked to overall sympathetic nervous system activity. This means that mindfulness meditation may lower blood pressure by lowering overall sympathetic nervous system activity within the body. The top takeaways from our research on mindfulness meditation is that it is a simple and accessible form of stress relief that can cause significant decreases in blood pressure by potentially lowering sympathetic nervous system activity.
So this led us to our proposed research of how might a combined intervention of aerobic exercise and mindfulness meditation practices be effective. As we've seen with the aerobic exercise studied within our review of literature, there are improvements in anthropometric values and in cardiovascular structure and function. However, there are no improvements in BP, and it's not suitable for all individuals, and there's the motivation and accessibility piece some may struggle with. Whereas with mindfulness meditation, it is novel and easy to practice. It has much evidence of lowering blood pressure more long-term than exercise, and has potential reduction of anxiety, although it does take practice, as those who lack attention spans may struggle, and it does not improve any anthropometric measures. Therefore, a combined intervention may produce simultaneous improvements in blood pressure, anthropometrics, and cardiovascular functioning. So for our proposed research, or for our problem statement, we have found that it is unclear whether a combined intervention of aerobic and mindfulness meditation may allow the population of African Americans to decrease blood pressure and simultaneously improve cardiovascular health. Therefore, our purpose is to examine the differing effects of mindfulness meditation, aerobic training, and combined interventions on blood pressure, anthropometrics, and other cardiovascular variables in the middle-aged African American community.
Our research question is, will a combination of aerobic and mindfulness interventions generate more significant improvements in lowering blood pressure and increasing cardiovascular health in the African American population? Our research hypothesis is that we expect the combined effects of an aerobic and mindfulness intervention together will not produce lower blood pressure and improved cardiovascular health measures in the African American population.
For our sampling, we will mail out to all the residents of Lakeland that we can and try to recruit middle-aged African Americans and exclude any with pre-existing medical conditions other than just a diagnosis of elevated blood pressure or hypertension stage 1. Then in pre-testing, we will take outcome variables of VO2 max, cardiovascular intermedial thickness, resting heart rate, anthropometric measures, resting blood pressure, and ambulatory blood pressures. And then we will randomize all participants into a mindfulness intervention only group, aerobic intervention only group, combined intervention group, and a control group. Then after 4 months of this protocol, outcome variables previously described will be remeasured post-test, and we will exclude any outliers or those who dropped out or did not follow protocol, and then analyze our results. For controls of validity, to control internal validity, we plan to have participants maintain the same diet and sleeping patterns and cease any moderate to high intensity activity in their lifestyle apart from any occupational activity. And we also want to control standardization of instrumentation by using the same instruments pre and post test and have sessions led by the same instructors, so the same teaching style will always be used. And for the motivational piece, as it is 4 months, is to have themes for cycling classes. And then all participants will be randomized to make sure there's no selection bias. And then for external validity, we aim to have a larger sample size of greater than 50 participants, so it can be generalized to a greater middle-aged African-American population. And since it is proposed to last 4 months, the Hawthorne effect should wear off over time with each session as they feel less pressured and ease into the cycle of things. And it is unavoidable, though, for the pre-testing and post-testing of VO2 max, as this is an all-out test with one researcher, and they're bound to feel the pressure to perform their absolute best in front of somebody else.
Measurements of height and weight will be completed using a scale with an attached height bar. The body fat of participants will be measured using BOD-POD, air displacement, plethysmography. A manual sphygmometer will be used to measure blood pressure, and an ultrasound machine will be used to measure carotid intima media thickness. And the Bruce protocol will be used to measure VO2 max of the participants. A heart rate monitor, stopwatch, metabolic cart, and cycle ergometer will be used during this measurement. As Tori stated earlier, participants will be divided into 4 intervention groups. The first group will go through an aerobic exercise intervention, which consists of an instructor-led cycling class on Mondays and Thursdays. The class will have a 5-minute warm-up, 30-minute aerobic training period, and 5-minute cool down. During the first 8 weeks of the intervention, cycling will be completed at an intensity of 65 to 75% VO2 max, and then at an intensity of 75 to 85% VO2 max for the last 8 weeks. The second group will go through the mindfulness meditation intervention on Tuesdays and Fridays. Participants in this group will be led through a meditation session by a professional. The session will consist on concentrating on breathing with eyes closed and allowing oneself to enter a non-judgmental state. For the first 8 weeks of the meditation sessions, they will last for 15 minutes, and then the duration will increase to 30 minutes for the last 8 weeks. The third group will be a combined aerobic and mindfulness meditation group. This group will attend the same cycling and meditation sessions as the aerobic and mindfulness group simultaneously. The last group is the control group, who will attend 40-minute lectures on healthy living 2 times a week.
And here are our references. So thank you for listening.